Okay, Warren, I'll continue to let people in as they come, but we can go ahead and get started with the group that we have.
All right. Thank you, Katie. My name is Warren George. I am the current chair of the Finance and Revenue Committee. I'd like to welcome you to the first meeting, our first meeting, the Finance and Revenue Committee of the Universal Health Plan Governance Board. I welcome our new committee members, and I welcome members of the public, many of whom I recognize, and I'm glad that you're here to observe the meeting. As I call the meeting to order, I'd ask Katie DeLuca to call the roll.
Thank you so much, Warren. Okay, Warren George.
Here.
And just to set the precedence, I'll go ahead and say, when you hear your name, just unmute yourself and say here or present or whatever you wish. Cheryl Ramirez.
Here.
John Santa.
Here. Sorry.
Richard Gibson.
Here.
Charlie Swanson.
Here.
Bethany Stairs. Jeff Goodman. Chris Hogan.
Here.
And Samantha DuPont.
Here.
Thank you.
Thank you, Katie. The goal of today's meeting is to develop an initial foundation for the future discussions of the Finance and Revenue Committee. Looking ahead at today's agenda, the members of the committee and our staff will be given an opportunity to introduce ourselves. We will review the committee charter, timeline, and process. Then we will hear a presentation by Kyle Easton of the Legislative Revenue Office, talking a little about the revenue fundamentals and some revenue ideas related to the task force. After that, we will talk about some of the principles that guided the task force, whether this group wants to use the same principles or modify them for our own. I will give a review of the actuarial analysis performed by CBIZ Optimus for the task force. Then follow that, launch into some of the basic possible lessons that we learned from our contract with Optimus and learn how to perform a sound analysis as pertains to establishing some attributes of a strong financial plan. Then we'll have a chance to reflect on the major points of this meeting and the committee members' hopes for our next step. We will have a chance for public comment and understand that we have no one signed up, but we do have a period reserved for public comment. Speaking of public comment, I would like to thank Lou Sininger, who shared a personal written story of a healthcare experience, which should challenge us all to do better. Before we start our introductions, Katie, could you remind us about some rules of using the virtual technology?
Yes, thank you, Warren. So when committee members, when you are here in this meeting, please keep your camera on and your audio connected. Please stay muted when you aren't speaking, but we will have members of the public. We do have members of the public now here able to join us, but they are not able to connect their video or their audio. So it's important to have your video on so that it can be distinguished that you are a committee member and you are participating. If you do have a question throughout the meeting or at the end, please use the hand raise function, and Warren or Executive Director Morgan will call on those with their hand raised. And that is it. As you know, when you join, you'll be made co-host, so you'll be able to connect your camera and audio. So that should be everything. If you have any questions, feel free to contact after. Thank you.
Okay, thank you, Katie. We will now start with committee member introductions. When called upon, please share your name, any pronoun preferences, say a little about yourself, including your interest in universal health care and your related experience. Then, once we're done, we can call on anyone who hasn't had a chance to introduce themselves. I will go first. My name is Warren George, he, his. I live in Corvallis with my wife Peggy. In my main career, I was director of primary operations and plant manager for one of the Mid-Valley's largest employers, and followed that by 12 years as a business management consultant. I believe in a universal healthcare system that provides all Oregonians with adequate care under one single plan without favoritism or individual obstacles to care. Prior to my appointment to the governance board, I served on the Joint Task Force for Universal Care as the appointed representative for financial management. My term on the governance board was scheduled to end in 2025, but family and health issues have led me to move my schedule up a year, and I will be departing the board November 1st, although I hope to remain actively involved in the issues. Cheryl Ramirez will be taking over as chair of the Finance and Revenue Committee. Cheryl, could you introduce yourself?
Sure. Good morning, everyone. Cheryl Ramirez, she, her. I was on the task force with Warren and John Santa, who's here too. My interest is, I believe healthcare is a right, and I see premiums and out-of-pocket increasing, and the cost shifting to both employers and individuals, and just don't think it's sustainable. So I'm really interested in joining many other countries. Do I call on someone next, right?
Yes.
Okay, I'll call on Charlie. Good to see you again.
Hi, so I'm Charlie Swanson, he, him pronouns. I did serve with Cheryl on a legislative universal access to healthcare work group. I've been interested in healthcare finance details for about 10 years now, with a variety of experience in looking at the details, and I including being a liaison to an individual, actually to an individual who did an analysis of healthcare finance in Oregon back in 2014. And also I very closely followed the RAND report, and I followed what's going on with the task force CBiz Optimus analysis as well. And I guess I'll call on John Santa.
Thanks, Charlie. I'm John Santa. I'm 74. I'm retired. Haven't made any money in 3 years. I retired when I was 70 and very happy about that. So I've been on Medicare for 9 years, and you know, I share that with other folks on the committee, but you know, after 50 years of being involved in delivering and administering healthcare, it is incredible to be seeing my friends and family, you know, getting sick and interacting with a very, very difficult health system. During my 50 years, I was involved in multiple attempts to get to universal health care in a multi-payer system. And I came to the conclusion 4 or 5 years ago that that was not going to work. And so got interested in single payer approaches, and was fortunate to be part of the task force, and learned a lot there, and continue to feel that while it may be difficult, that's better than impossible. And I think that I'm looking forward to being involved in this effort to keep that approach front and center and figure out how to make it work. Thanks. Let me see who else is on here. Oh, Dick Gibson.
Good morning. I'm Richard Gibson, he, him pronouns. Thank you, John. I was a family doc and an emergency doc and spent a lot of my career putting in electronic health records for physician offices and for health systems. I did data analysis for Providence Health System, and now I do healthcare cost analysis for Comagine Health, a nonprofit in 8 Western states. The reason why I was motivated to be on this committee is because as a family doc and emergency doc, I could see that illness and injury can be very challenging at best for families, but they shouldn't also have to worry about financial devastation. And I think what the work we're doing here is at least we can limit that that challenge to the clinical challenges of healthcare. Thank you. Let's go with Chris Hogan, please.
Morning, everyone. My name's Chris Hogan. I've been with Advanced Health, a small rural CCO, for about 10 years now. I'm currently their CFO. My background is in finance and analytics. And what I hope I can bring to this committee is an understanding of healthcare in rural Oregon. Rural providers and patients have a unique set of challenges. And I think they're affected in different ways by the way this project is financed. So I hope to advocate for them in this project. Samantha?
Hi there, my name is Samantha Dupont. I currently serve as the Certified Community Behavioral Health Clinic Program Administrator with the Oregon Health Authority. For those who might not be familiar with that program, it's a federal program, currently a demonstration program that is modeled after UHPGBs and a payment model, along with some other good stuff around behavioral health transformation. I've been with OHA for about 2 years now.
You're on mute now, Samantha.
Oh my goodness. I had a whole spiel and no one heard it. Okay, I'll start over. Thank you for your patience. I'm Samantha Dupont. I currently service the Certified Community Behavioral Health Clinic Program Administrator at the Oregon Health Authority. For those who aren't familiar with that model, it is a behavioral health payment and delivery system transformation model that is modeled after the FQHCs. Prior to this role at OHA, I oversaw a number of our major research contracts on behavioral health capacity and need, including a financial analysis of SUD public spending in the state. Prior to OHA, I worked at Kaiser Permanente for 10 years in the National Government Relations Department, focusing on payment and delivery system reform, pharmaceutical pricing policy and anti-competitive behavior, behavioral health workforce, and a number of other issues while there. I'm here really, I believe in universal health care. I think universal health plan is a step forward beyond, short of that. And really it just stems from knowing that we have a 2-tier system in this country, and I want to see a system that's equitable. And I believe that a universal health plan can help get us there. In terms of the revenue side, what I bring, my corner of the universe is in behavioral health financing specifically. So I hope to peel back layers of the onion in that space, especially. And with that, I believe Megan might be next.
Let's go with Bethany Stairs.
Good morning, everyone. My name is Dr. Bethany Stairs. I'm a nurse practitioner here in East Portland. I have been in healthcare for about 20 years, mostly working in community health. Currently, I'm the medical director at FQHC out here in East Portland, as I already said, Gresham area. I am very interested in Universal Health Plan. I've had quite a bit of experience working to make healthcare more accessible and more equitable for folks who are underserved. And so I hope we can come up with a sustainable plan for the state. And my revenue experience is primarily as medical director. So working budgets and looking at cost visits, how to increase our revenue and be sustainable without burning out my clinicians. So that's it for me. I joined late, apologies for that. So I'm not sure who is left to go.
Well, Bethany, thank you. Last up would be Jeff Goodman.
Good morning, Jeff Goodman. I am on the Medicare and have been since I turned 65. I have been involved in finance and business my entire life. I'm currently the treasurer of the Clackamas Free Clinic, past member of the Legacy Foundation Investment Committee, and have a belief the same as the late Charlie Munger at Berkshire Hathaway, where he talked about the state of U.S. healthcare being the whole damn system is going wrong. It's ridiculous. Or with his partner in business, Warren Buffett, who's called the healthcare the tapeworm that's eating the economic system of the country. So we have to be able to do something better.
Thank you, Jeff. I just want to check, Helen Belanca, are you here attending as a guest?
No, she is not.
Okay, thank you. Then I would like to move to Morgan Cowling, who is not only our staff support for the Finance and Revenue Committee, she is the executive director for the Universal Health Plan Governance Board. Morgan, if you could introduce yourself and your staff.
Great, thanks, Warren. Hi, everybody. My name is Morgan Cowling. I use she, her pronouns, and I'm the executive director of the Universal Health Plan Governance Board. And I'll be the primary staff person along with Katie DeLuca for this committee. But it's not just the two of us. There are lots of other people who will help support this committee's work. And so I just wanted to take a couple minutes to introduce those who are on this in this meeting today. Katie, would you introduce yourself?
Yes, thank you, Morgan. My name is Katie DeLuca, and I prefer she, her pronouns, and I'm the executive assistant to the Universal Healthcare Governance Board. And so, yes, I will be scheduling your meetings, sending out notes, and making sure you have all the communication and direction that you need. So thank you very much. I'm happy to be here.
Thanks, Katie. And then for those of you who don't know, there's a couple of the staff who were kind of under the Universal Health Plan Governance Board and are housed at the Department of Business and Consumer Services. So myself, Katie, and Jenny Donovan, who I believe is here, she listening in. Jenny, do you want to say hi? Maybe not. And then in addition to the three of us at the Department of Business and Consumer Services, we have partnership and staff at the Oregon Health Authority who are providing support to this effort too. Laurel Swerdlow is on. Laura, would you like to introduce yourself?
Hi, everyone. Can you hear me?
Yes.
I'm having computer issues, so I'm joining by phone. My name's Laurel Swerdlow. I use she and her pronouns. I serve as the Office of Health Policy Coverage Team lead. The coverage team includes this broader single payer body of work, and I look forward to supporting DCBS and all of you and the board in this important work. I'll hand it over to Devlin.
Good morning, everyone. Devlin Prince, he, him, in the Oregon Health Authority. I'm also in the Office of Health Policy on the same team as Laurel. And I believe, Jessica, are you on?
Yes, I'm here. Good morning, everyone. My name is Jessica Marino. I use she, her pronouns. Also on the team with Devlin and Laurel and Danielle, who you'll meet right after me. Today is my second day with the government, so very much here to listen and learn and figure out how I can best support you all. Danielle?
Hi, everybody. I'm going to start video, but the Zoom link won't let me because I'm a guest, but can you hear me okay? Fantastic. I recognize many of you from the Universal Healthcare Task Force. I was the assistant there, so I sent a bunch of emails and scheduling and such. So excited to be here. It's also my second day and I'm excited to learn.
Thank you. And then in addition to the folks at the Oregon Health Authority, we also have a partnership with OHA and Health Management Associates, and Janine Smith is here today as well. Janine, will you introduce yourself?
Hi, I'm Janine Smith. I'm part of the Portland office of the Health Management Associates. We helped to support some of the work of the task force a couple of years ago, and also have worked recently with the Washington State Universal Healthcare Coverage Commission. And I'm looking forward to continuing to work with all of you. And I know many of you because it's all John Santa's fault that I spent 15 years in state government at what became OHA and was their chief medical officer and head of their policy shop. So have a long history with Oregon's experience in universal coverage.
Thanks, Janine. And then I see Jenny was able to unmute and put video. Jenny, do you want to introduce yourself as well?
Sure. Apologies. I was a guest and wasn't able to unmute. Good morning, everyone. My name is Jenny Donovan. I am the Senior Policy Analyst with the Universal Health Plan Governance Board at DCBS. And so I work with Morgan and Katie there and the rest of the great team. So excited to hear what you all do this morning.
So thank you, everyone. It's pretty obvious that we actually have assembled a pretty special team here to work on this mission of implementing universal health care in Oregon. We will now begin a review of our committee charter timeline, committee process, some rules. As far as decision making, our committee will basically follow the same rules as the governance board follows in its official policy and procedures. To conduct any business, we need a quorum of any 5 of our 9 members to be present in person or virtually. And most of our meetings, or perhaps all, will be virtual. Once a quorum is achieved, a simple majority of those voting is sufficient to pass a motion or recommendation. Our board likes to operate with a goal of consensus to take advantage of individual views, experiences, backgrounds, training, expertise. We've been using a tool called Fist to 5, which allows the group to test consensus on an issue. 5 fingers, holding up 5 fingers, expresses full support of a proposal under discussion. Fewer fingers expresses a range of concerns or need for more information. A fist expresses full and sincere opposition. And once we kind of know where people have issues, it helps the group, helps to group to work toward consensus. For our committee to make an official recommendation to the board on any issue requires a roll call vote of the committee. Committee members should not abstain from voting unless they have a conflict of interest in the outcome of the vote. If you have any question about a possible conflict of interest, you should discuss it with the committee chair, or board executive director, Morgan. As part of our committee commitment to be sure that all voices are heard, if there are votes, roll call votes, and some votes in the minority, those members may submit an explanation of their vote and provide an alternative proposal. Moving on to the objectives. Committee objective is to design a unified financing structure for the Universal Health Plan, including a trust fund with sufficient reserves, studying the impacts with respect to specific types of employers and households, and within the context of avoiding legal challenges under ERISA. Now moving on to our charter tasks. And Morgan, would you be willing to jump in and take this part from here? Thank you.
Sure. And before I jump in specifically to the tasks, I just want to add a little bit of context for this agenda item. There's really 3 documents that kind of talk about the role of the board, the role of committees, and the role of committee members. We're primarily focusing on the committee charter, but it's important to note that the committees are also need to adhere to the board policies and procedures. And the board policies and procedures say, unless otherwise specified by the board, all work groups and committees are subject to and governed by all relevant board policies and procedures. And some of those policies and procedures are very similar to what Warren just outlined with how votes are taken, how quorum is decided, but also the board policies talk about participation and that strive for consensus and being an active participant and a respectful participant and listening to others and working through challenges. And so I just thought that aspect of the policies and procedures was a good one to call out. So jumping back into the charter tasks, I won't read through this list, but I have kind of been thinking in my mind that these are kind of grouped by kind of phase 1 and phase 2 that we'll talk a little bit more about, but that the list of attributes of a sound financial plan is something we'll be talking today. We'll kind of go through a timeline and work plan, and you'll see that understanding the current spending and developing a cost target. Those are tasks that the committee will be taking on in the near future. Reviewing methods of revenue collection and reviewing and updating and building on the revenue options. Kyle Easton from the Legislative Revenue Office will be talking about those revenue options that the Joint Task Force looked at. And then I've been thinking about these last 3 as kind of a phase 2, describing the impact of the revenue or taxes on large and small businesses and households, identifying revenue, and comparing and contrasting those current mechanisms. So next slide, please. Warren, do you want me to keep going or? Okay, cool. So you'll see the charter deliverables really align with the overall objective of the committee to identify that financing strategy and to make that a recommendation to the board on that strategy. Next slide. So how is the committee going to accomplish this? So I kind of outlined steps for this first phase. Review the work of the Joint Task Force, make sure in this first meeting there's a real grounding in the work that has come before and that work that the task force did. Review and discuss an update of current health spending in Oregon, understanding where that health spending is coming from, who is making that health spending, identifying if there's any missing health spending. And then really jump into potential alternative revenue options. And the idea with the work plan for the governance board is that the first major task is for this committee to recommend a total budget for a universal health plan with current health spending and revenue, so that there is a budget, a total pie, as I keep talking about, a total pie for the universal health plan. Once you have that total pie, you'll recommend that to the board, and then get some community feedback on that. And from the board, and then our community engagement committee will also do some community outreach, business outreach on those proposals for the revenue options. And then we'll need to bring the plan design and the finance and revenue committee together to look at that pie that the revenue committee has identified that is made up of current health spending that can be shifted to a universal health plan and new revenue that can be raised to fund the universal health plan, and compare that with the plan design that the plan design has developed, and look at those two pies and see how they compare. And if they're aligned, that is great. And if the plan design has developed a design that is larger than the pie developed by the committee and approved by the board, then the plan design and revenue committees will need to come together and look. Do you look at additional revenue options, or do you look at plan design changes and kind of work through those challenges? Next slide, please. So that's kind of like the big picture, how the work will be done. So kind of breaking this down into the next several meetings. We're having the committee orientation today. Next meeting, we're going to dive right into that health spending. How much does Oregon currently spend on Medicaid? What are the investments in behavioral health? What are the revenues that could feasibly be shifted into a universal health plan? And then in December, start looking at some revenue alternatives. Kyle will be talking today about the revenue options that the task force looked at, but we'll have a discussion in December about, are those revenue options that this committee wants to continue to look at? Are there other revenue options that should be on the table? And then in January, we'll dive into some of those structural challenges that Warren mentioned with the ERISA, the Employee Retirement Income Security Act. Make sure that those funds can be put into that trust fund that's part of the objective, and spend that meeting really taking a deep dive on those challenges. And then in February and March, dive back into the revenue options and that cost target and figure out kind of that overall budget or pie for the universal health plan and what revenue options to put together to develop it. And we figure that might take at least 2 meetings. That's a pretty big chunk of work, and working through, and then have 2 meetings in April and May to hold it if needed. But really, the hope is that in March, you're all ready to make recommendations to the board. The board would kind of give some endorsement of those, and then they would go out for community feedback during April and May. And then we would come back in July and have that joint meeting with plan design to work through to compare the revenue and budget with the plan design. I'm going to pause there and see if there are any questions. Charlie, I saw your hand go up first.
Okay, so I had questions about trying to get help in the beginning task, which is current health spending in Oregon. Are we going to be able to communicate with people within OHA and amongst ourselves to try to help make sure that we have reasonable data for current health spending?
Yeah, this is one of the tasks that the Joint Task Force did a lot of work in this area, so we have a good starting place to work from. And HMA and Janine Smith and Anya are currently helping us pull some of those numbers and update the information from the Joint Task Force. And this is one of the gray areas where we do have connections with OHA, and can get information from them.
And so if we have specific questions, how should we go about forwarding that to you or OHA or both? And, especially related to questions that directly come from what the task force did and what CBIZ Optimus did. So
Yes, please send them to me. I think this is exactly, I'm the point person for this committee. So to make sure that questions aren't going to different places, send them to me. And I think that will be, then I'll collect those, and we meet regularly with HMA and OHA and can work through those for the November meeting. Thanks, Charlie. All right. I'm sorry, I didn't see you went next, but Samantha.
Actually, piggybacking off of that, I noticed in the report there were several areas that said this needs more analysis. What is the plan for that additional analysis? When do we expect to see it? Another question I had, and forgive me if I missed this, but what will be the feedback loop with the operations committee? And then, I see we're meeting through July. The plan isn't due to the governor until 2026. What happens in that time period?
Great question. So I'll take them in reverse order. So this work plan is really through phase 1. So I think the meeting with that joint meeting with plan design will help identify, like, if finance and revenue kind of comes back and kind of digs back into additional revenue options, there might be additional work there. But then there are those other 3 tasks that when I went through the task, I kind of said we're in phase 2. Like, once you start honing in on those revenue options, identifying the impact of business and households, there's an economic analysis, and comparing and contrasting current work. So this timeline and work plan really just goes through phase 1. And then some of that phase 2 will be determined based on that joint meeting and kind of the direction of the committees and that the board wants to take. But then there'll be also kind of still meeting through the second half of 2025 for that kind of phase 2 of those other aspects in the work plan. So at the next meeting, I'll make sure to kind of do a brief sketch of that phase 2 as well, so you can see. But we just wanted to give you a sense of kind of the immediate tasks to develop this overall budget. I was going to work backwards and I forgot the middle question.
Feedback loop with the operations committee.
Oh, great question. So the way we're phasing in the committees is to start with the finance and revenue, because it's kind of central to everything, right? Figuring out this financing plan is like, it's central in the legislation that created the governance board. It's one of the missing pieces that the joint task force didn't really land on. So getting this body of work is like the first piece. Community engagement and communications will be the second committee that will launch in 2 weeks. Plan design will be launching in early November, and then operations is really going to be the last to launch, because so much of this other, like how to finance it, what does the plan look like, are pieces that the operations committee needs to start their work. So we're kind of phasing them in that order. And then the goal, and one of the things that the board will be talking about, is making sure that each committee has these 2 board members on it. So there's really good communication between the committees and the board. And that as these pieces continue to develop, that there's this feedback loop with the board, so that the members of the chair and the other member of the operations committee are staying in close connection. We haven't planned for a joint meeting with operations. It's more that feedback loop that all of the recommendations from the committees get to the board, so that the other committees kind of know about it, and really relying on the board members for each committee to help provide that communication link between the 2. And then I do remember your first question was the areas of the report that say additional analysis is needed. And at a very high level, when you look at the Joint Task Force report and the additional areas that need additional work, that almost totally one for one matches up with the deliverables in Senate Bill 1089 that created the governance board. So for the most part, where the Joint Task Force report said we need more work, you can see that there's a associated deliverable in Senate Bill 1089 that says there needs to be more work done. There needs to be a financing plan, or but if there are specific questions you have about some additional analysis needed, please send me an email and I'll take a look and let you know if it's somewhere in our work plan. Thanks, Samantha. John.
Yeah, thanks. I'm without camera also, apologize. I'm just wondering, you know, the task force made a number of assumptions, and some of them very early on that drove the process. And, you know, many of those assumptions drove resource decisions in the $1 to $5 to $10 billion. And from a finance point of view, it seems like, you know, those could be, I could give you a list of 10 of those tomorrow, that it would be helpful to the finance group to know which direction the plan design committee was leaning in. My favorite example would be from the outset, the task force made the decision that the budget for the delivery system would be flat. Okay, the delivery system would get as much on day one of the single payer as they were getting on the last day of the multi-payer system. Okay, that was a multi-billion-dollar decision, which at the end, the task force actually realized that probably wasn't reasonable, and they ended up taking 4% of the administrative costs that were saved on the delivery system side. Because in a single payer done well, there's going to be a 20 to 30% savings on the delivery system side in terms of administrative costs. The task force left that with the delivery system, which meant that the revenue had to be raised to drive that. That was an incredibly key decision, and really limited many of the options that the finance and revenue decision makers had. So I'm just hoping that to some degree, some of those decisions can be made early on to give the Finance and Revenue Committee, you know, some levers to work with. Thanks.
Well, John, I really appreciate those comments, and I hope you send me that list. That would be just helpful to see all in one place. But I also think that this is the plan for finance and revenue to determine the budget first, I think, is to say, like, here is the budget that we need to figure out with plan design. Does that budget that you all figure out with current spending and new revenue or revenue shifts that can be funded, and send that to plan design and have that discussion with plan design about looking at what are those assumptions and how to manage to a budget that you can raise revenue to support. So hopefully this approach is a little bit different than the approach from the task force. Jeff.
Sorry, did you?
Thank you. I had to get unmuted. This is a follow-on to John's comments and questions, which is, I know there's been a lot of good work that's been done prior to the formation of this, which is, it's much appreciated and it's good work. but can you provide to us at our next meeting or prior to our next meeting, what is the delta of additional revenue that we're looking at are based on the assumptions that are going into that? Because if we're simply talking about reshifting or savings that come from adoption of various programming, that's very different than if we're talking about, if you will, additional services, additional coverage, et cetera. So I'm trying to get a handle for the discussion. Are we looking at zero? Are we looking at another 100 million a year, another billion a year? Because what kind of nut we're looking at for the delta will drive much of our discussion. And so if we can get a sense of that in advance of our next meeting, I think that will be helpful for our conversation.
Got it.
Jeff, I think you'll get maybe a little bit of flavor of that in later presentations today, but we've got that on the list and can address this. We're running low on time, so if we could just take the two more questions. Cheryl.
Mine is really super simple about process, but I did want to know that those were good comments. And I recall on the task force that we were fairly conservative with our estimates. I personally think we could revisit those estimates. So I would say that. My question is on, for Morgan really, on when a committee member has a question, is it possible to copy me on that when they send it to you, just so I'm aware of maybe where we need to dig a little deeper, focus our energy? I'd appreciate that. Thank you.
Thanks, Cheryl.
Charlie.
So I've got one other question or comment, I guess. And part of the decisions of how much money we're going to need depends upon how we pay providers. And I'm thinking in particular about global budgets for hospitals. And it seems like it would be useful to very early on learn more about how that's done in at least another country. For example, British Columbia pays hospitals with a global budget, and I've been in communication with someone who understands quite a bit about that process and is willing to help us out. It seems like it would be very useful for both this committee and the Plan Design and Provider Payment Committee to learn more about that very soon, so that we can make a decision about, well, are we going to have that savings, and therefore are we able to make use of that simplification, I guess, administrative simplification. So I'd like to put that out there and try to figure out, is there a way that we can organize that meeting fairly soon?
Yeah, at least the way that this work plan envisions is that provider reimbursement, cost containment, all of those conversations are on the plan design. Can you hear me?
Yes. Yeah, sorry.
Okay. That provider reimbursement, cost containment, that those conversations are on the plan design side of things, and in the plan design committee. So to the extent that there are conversations about how those payments are made, payments to hospitals, that would be in the plan design committee.
Right, but it's going to have major effects on the revenue that we need. So it seems like we have to be involved in that in some manner. And this, again, to decide the amount of revenue we need to do that soon, in my view.
Okay, thanks for the great discussion. I would call your attention that the board's policies and procedures are available on the website and should be read by all the committee members. We have a guest speaker now, Kyle Easton from Legislative Revenue Office, who worked with the task force to talk about review of some of the work that was done on revenue in the task force. Kyle, could you unmute yourself and come forward and tell us how you feel about accepting questions as you go along, or a preference to wait till the end?
Yeah, thanks. Good morning, everybody. And yeah, no, if there are questions, please.
So sorry, Kyle, to interrupt. You're just a little bit quiet. I'm not sure if quiet for everybody else, but are you able to turn your volume up just a little bit?
Trying to stand a little bit closer. Can you all hear me okay now?
Better.
It's a little better, yeah. Thank you.
Okay. Sorry, I got a new microphone, so I haven't actually had a chance to test it on Zoom. So yeah, as I was saying, Kyle Easton, Legislative Revenue Office, and yeah, no questions throughout. That's perfectly fine. If people want to raise their hand or if they want to jump in, I'll try to keep an eye on the participants and the hand going up. But Katie, maybe you can help me with that as well. But yeah, so just briefly, the Legislative Revenue Office, what are we? Why are we even involved? So we are the revenue scorekeepers, if you will, for the legislature. So any legislation that's going to eventually work through the legislative process would be scored by the Legislative Revenue Office. So we'd be responsible for making the ultimate estimates of what would be the revenue raised from a new tax to fund or taxes to fund universal health care. So that's how we got involved, and we provided some, I'd say, some high-level information to the task force, the Universal Task Force previously. And so that's what I have for you today in terms of a presentation. Yeah, thanks, Katie, for moving that. We can go one more slide as well. Would be great. The idea today is to discuss what the task force discussed as well, and where the task force landed in terms of revenue, but also to give even back up a little bit from that and give a little bit of a high level perspective of potential revenue sources as well. Hopefully provide some context on how the task force got to where it did. But to also do that in a very brief manner as well, as I know a number of people who are on the task force are familiar with. This was a process that took some time. So I'm going to be doing a very quick overview of it and very concentrated as well. So in terms of revenue policy options, the discussion today, again, I'll start with some of the high level stuff. So the first question is, who should bear the funding of universal health care? That was a topic that came up. And one of the key, I think, ways in which this was viewed at the task force level was there is a funding already in place for health insurance, really. And then universal health care would be something new. So this would require new revenue sources, but in many ways, these are replacing existing sources. So this is the existing employer provided or employer provided health insurance. That could be replaced by a different funding source, but those costs would go away for the employer and then might be replaced by a new revenue, a new tax. So that's a key thing to keep in mind when we say this is new revenue coming in. In many cases, it's replacing an existing revenue source that could be going away because employers should no longer be purchasing health insurance for their employees. This would all be coming through the universal health care. In terms of multiple revenue sources, how do they intersect, interact? That's something just to keep in mind, I think, going forward, especially when we get into the discussion on the proposals where a personal income tax and a payroll tax, which can certainly have some overlap. And then the last two bullets I have here, the key revenue levers, I think that goes really with the tax base, tax rate, administration. And so an example of like a lever might be having higher marginal rates or different marginal rates. So if you want to make the tax more progressive, you might have tax rates go up as income goes up, for an example, of a personal income tax. And then also the tax base, the bigger your tax base is, the broader it is, the more revenue you can raise with a lower rate. So that's something to keep in mind. And then finally, with just administration, are you talking about a new tax or perhaps piggybacking off of an existing tax base, like something like the personal income tax? An example of a new tax base with new administration would be something like a sales tax, which would be something new to Oregon. We can go ahead and go for one slide here, or go ahead and go two. Thanks. In terms of comparison of tax bases, this was just to give a sense of how the committee got to where it was, but also just to give you all a sense of what are the tax base sizes that are in play here in Oregon today. These are tax base 2021, billions of dollars. In terms of the first one, a payroll tax, it's about $126 billion. That's the overall base. So it's a pretty large tax base, and that allows you to apply different rates to that tax base, gets you to basically how much revenue is raised. That's the simple nature of it. In terms of personal income tax, that's about $154 billion. It's a little bit bigger than the payroll tax because, of course, personal income taxes would include things that would be in payroll, like wages, but it also captures some of that other types of income, such as capital gains, investment incomes, dividends, those type of things. So a little bit broader than just the payroll. Property tax, I included that one just to show how large that can be. But again, property tax would be a completely different thing of levying a new property tax and would have a lot of interaction with local revenue sources, right? Property tax is right now used by local revenue or local governments and school districts. The next one we have there's the corporate income tax. This came up during the task force, part of the discussion of if you're implementing a new income tax, would you want that to be on just the personal side of things, just individuals, or also on the corporate side of things? And one of the key things here on the corporate income tax is just its relative size. It's about $17 billion. So the task force discussed this, but because of the tax base being relatively small, you do need a large rate to really raise a significant amount of revenue. So this is quite a bit smaller than, say, the personal income tax base. Retail sales tax, that's another one that would be brand new to Oregon. Again, Oregon doesn't have a broad-based sales tax, but it is a sizable tax base, so it is something that's available. The next one over, commercial activity tax, that's based upon our existing corporate activity tax that's in place. Again, that's about $216 billion, so that's another large one. And then the last one I included here was just to give a sense of how different tax base sizes we have here in Oregon. It's something like cigarettes, because that comes up. It's like, well, okay, cigarettes, let's use cigarettes to pay for universal health care. The tax base in that case, this is packs, but it's 100 million packs is a rough number of how many packs are sold per year in Oregon. And it just gives you a sense like, well, could you just tax cigarettes and pay for universal health care? And well, no, the answer is no. It's not a big enough tax base. It's not going to get you there. But there could be other reasons to do something like that for, not to say that any revenue doesn't count, but also optical reasons as well. Just levying the tax, not just necessarily to create revenue, but more of just putting the tax on cigarettes. But again, that's a very, very quick overview of the different tax bases that are available. We can go ahead and move forward if you could, Katie. Where the task force landed was really focusing in on the payroll and the personal income tax. And so I'll finish with some slides on this, but those were the two tax bases that the task force focused on. Yeah, and you can go ahead and go for it. Thanks, Katie. That was moving to slide 8, I think works. Great. So the payroll tax, this was the first one, one of the two that the task force focused on. And payroll tax, what you're talking about here is wages, and then a secondary category can be self-employment income. So for wages, this could be focused on, say, the employer would pay a tax based upon the wages paid to their employees. Part of the reason I think the task force looked at this is that in many ways it compensates, or it's very similar to the employer provided health insurance. So if that went away, that's a reduced cost for employers. They no longer are responsible for paying for all or a portion of their employees' health insurance. So this new payroll tax could replace that in some cases. So this would be the responsible of the employer. Self-employment, that's just, you can think of those are people that are self-employed. So they own their own business, they pay a payroll tax on the wages they would otherwise pay to themselves, even though they don't pay specific wages. So that's similar to how people, self-employed individuals have to pay Social Security taxes, Medicare taxes. Same idea there. In terms of the revenue numbers, and I should have mentioned this in the beginning, the numbers contained in the slides here, most of these are going to match what was in the task force report. So these numbers are dated. They were projections made 2 years ago of what 2026 would look like. So these are dated numbers, but they do match with what's in that final report. So that's the reason I left them the same. But any numbers going forward would of course change because again, they were projections made a couple of years ago. But what was driving in many cases, what the task force was looking at in terms of revenue was, and this is getting to the discussion that happened just a few minutes ago, was what's the need for the universal health care? Because the first question was, well, what's the need? And then you can find a revenue source, or you can design, or you can use a revenue base and apply certain rates to get you to that revenue lift you need. And that was really the driving force of the discussion. It wasn't, we're going to raise X amount of dollars, this is how we do it. It's how much do we need raised, and then how do you want to get there? So the first question is really, what is the amount of money you need to begin with? But one of the guiding principles, I think, with the task force was to try to make these a progressive tax system. So when I mean progressive, I just mean as income's going up, the amount of tax that someone would be responsible for paying would also be increasing. And you do that through increasing in marginal rates. So in terms of the payroll tax, where the task force landed, and this was really just, these were high level. I don't think the task force actually put in official recommendations. These were just where they landed on, these are options that would yield the revenue necessary that was under discussion at the time. Was a progressive payroll tax. So the first $160,000 in like an individual wage would be taxed at 7.25%, and then the amount above 160,000 would be taxed at 10.5%. And that would yield, it was expected to yield about 12.3 billion in 2026. Again, these are pretty high level estimates. Preliminary, I would say, is a fair way to describe them, and they're also static. So they don't really take into account all the economic shifts and changes that would occur if you shifted to a universal healthcare tax. But that was the first one. So that was the payroll tax. If we go over to the personal income tax, again, the tax base, this was described previously. The slide here in front of you is just giving a sense of, well, of the existing personal income tax that we have, this is based upon Oregon's existing personal income tax. You have different types of income. And that's what the pie chart in the middle is you have the earned income. Those are going to be things like wages, things that you're earning that income. Unearned income is going to be more of like investment income. It might be dividends. Could include things like capital gains. That's the kind of the orange color of the pie. And then you have also have business income, and then the last one there is retirement income. And retirement income, that one is key to point out in that Oregon, in its constitution, does exclude social security benefits from taxation. So that was the assumption, is that any personal income tax levied for universal health care would also exclude social security income, as that's in Oregon's constitution. So absent the constitutional change, that's something you couldn't use as part of the base. And Charlie, I see you have your hand up.
Yeah, so can you break down the retirement income into that Social Security portion and other retirement at some point? Because again, as you just mentioned, Social Security income is not taxable, but other retirement income is.
Yeah, just making a note on that. Yeah, we could definitely break that out a little bit more detail, because a lot of that is Social Security, but there are other forms, of course, that would be tax that might have been tax deferred, or they could be the other way where they're not subject to the existing income tax going forward because they're, say, invested in like a Roth IRA or something along those lines. But yeah, we could break some of that out to give a better sense of how much.
Well, I'm also just thinking of like pensions that are not Social Security. So.
Okay. Okay, and then the last thing, just over the chart over here on the right, really this is just showing you have the orange bars, which are the number of tax returns that we have existing for personal income tax. And then the blue bar is the total income. And so you can see you have more returns, and that I guess it's working from adjusted gross income. So as you work your way to the right, you're going up higher income. But so we have more returns at the lower income, and then more of your income is coming in on those higher income returns. And that's just showing kind of how that exists today, and really where your revenue could be, your revenue sources could be coming from, depending on how you design personal income tax. You can go ahead and advance one slide, please. So in terms of what the the healthcare task force was focusing on. They were looking to utilize, I think, to piggyback, if you will, to work within the existing personal income tax, but to do things a little bit differently. Just simply, we're going to use Oregon's existing personal income tax and just throw an extra rate on it to that effect. Instead, the task force was focusing on this idea of poverty level and using that as a basis of how to determine someone's individual tax base and what income would be applied against their tax rates. So federal poverty level is not something that's specifically in our existing personal income tax system, but there is something that we were saying that you could have a quasi federal poverty level using things that come on the income tax return presently. But in a general sense, poverty level is based on your household size. So the larger that a household, as a household grows, the amount of income needed to reach 100% of federal poverty level goes up. And that's just what you see in the table in the middle of that slide. This was 2022 poverty level based upon household size and where those households land. And really the way that this generally works is poverty levels, it's a pretty low number. So the basis often becomes 100% of poverty level, 200%, 300%, 400%. So these are used in other programs. So it's something that's certainly familiar from a policy standpoint, but it's not something that's in the existing personal income tax. But it could be layered over the top of the existing income tax. In terms of tax rate scenarios, one of the things I mentioned, there was a lot of discussion, of course, in the task force as they worked through this, but one of the discussion topics I thought worthwhile to bring up was this idea of the premium cap. So the idea here was, would you put in place a premium cap that would cap the amount of personal income tax someone would have to pay equal to the cost of their health insurance? So if we go forward one slide, the idea would be if someone had, and this would really be the case of someone who's in the higher income, maybe absent the premium cap, they would have a tax liability of say $100,000, but the cost of their premium is $25,000. That would cap how much they would pay at $25,000. So you would never pay you would never pay more than what you're actually receiving in terms of the cost of the health insurance. Now the challenge with that, of course, then is it caps what predominantly those high income taxpayers would pay, and it would require a much higher rate to then get to the same amount of revenue. As opposed to not having a premium cap, you can keep the rates a little bit lower because you do have some of those high income individuals, taxpayers that would also have high liability. And we can see that in the next slide as well. Has some of that. This is where you're seeing the average tax liabilities here on the left. And again, the cap used at this point, for example purposes, was about 25,000. And so you can see as you move up that income category, it does cap at about $25,000. Whereas the chart slightly to the right, the orange circles, that's the average tax liability without the premium cap. And in that case, you can see as income's going up, your tax revenue or your tax liability continues to go up as well. There is no premium cap, so you're getting more of that revenue from those high income taxpayers. And that's where the task force landed, was to not include a premium. But it was a discussion, a prominent discussion, so I thought it was worth bringing to your attention. But that's an update on what was discussed there. The next slide is really just showing the same information in a slightly different presentation of just effective tax rates. I think the key takeaway here is without a premium cap, you have a progressive tax system based upon the rates that the task force is looking at. Whereas if you have a premium cap, you begin to see the tax liability as a share of income going down as income continues to go up because they're capped at that $25,000 in liability. So the premium cap really does change the progressive nature of the tax system as well. So that was another key consideration. I think probably why the task force landed on no premium cap as well. Okay, so in terms of what were the final proposals that was included in the final report, as I mentioned, there's two policies really. You had a payroll tax and a personal income tax. So the first one was a payroll tax. The tax base in this case would be private and public employers and the self-employed. And so the rates, I mentioned this earlier, the first 160,000 was a 7.25%, income above 160,000 at 10.5%. So it's a marginal change there. So it's only the first dollar above 160,000 is taxed at 10.5%. And the revenue yield, it was expected to be about 12.3 billion. Moving over to the personal income tax, this one, again, the task force was looking at leveraging poverty level for the tax base. So the first 200,000, so for those, I guess it'd be for those households, income less than 200% of federal poverty level, their tax rate was 0. And that was the idea, similar to how, say, standard deduction works or something to that effect in income tax. You're not initially taxed. There is the first 200% of income is not subject to the tax. Now, for those at 200 to 250% of federal poverty level, the tax rate goes to 1%. So it becomes a relatively small amount. As you move up, that tax rate is marginally increased. So 200 to 300%, the tax rate is now 1.75%. It goes to 2.5% from 300 to 400% federal poverty level. And then for those households at 400% or above federal poverty level, that income above that 400% is at 8.2%. So it's a big step up in terms of a rate once you get above 400% of federal poverty. And that would, we were looking at about 7.6 billion. Combined is about $19.9 billion in revenue from a static estimate. And this, I should note, this ignores sort of the phasing of the new tax and all that would go into it. This is more just to give a sense of, well, if we need about $20 billion, what would a payroll tax in combination with a personal income tax, what would those rates have to look like in terms to raise that revenue? And Chris?
Thanks, Kyle. I like graduated taxes. You know, I'd be curious to know, you know, how these costs are being borne right now by the system and which demographics those are affected, and what, you know, and how that compares to what we're proposing. Because I think it probably creates winners and losers, and I think that goes into, you know, the political problem of this project. You know, I think what you're saying is this payroll tax is at least partially offset by the existing employer contributions. Probably personal income tax is partially offset by current individual contributions. So, you know, what's the landscape comparison look like?
Yeah, that's a really great question, and it's certainly one that came up as well as with the task force. And I don't think there was never a final answer in terms of here's a perfect model that has all of the cost drivers or the cost today, and then layering the tax system over the top of it. I know previously Optimus put together some just example slides, so they weren't. It was just like, well, here, let's take like 4 employers or 4 individuals and show how there are winners and losers. But I don't think it got to the point of there's going to be X number of winners, X number of, you know, quote losers, and this many more or less break even. But yeah, that is, I mean, certainly with no premium cap, the high income personal income taxpayers, I think that's probably fair to say. You know, they're going to be paying more than under the existing system most likely. But in a lot of places, yeah, it depends upon it in where the employer is today and whether that the healthcare costs, whether the payroll tax would be less than what they're presently paying or more. But yeah, there would be a lot of shifting.
Yeah, I think maybe honing in on how middle class taxpayers are affected, and how this affects, you know, different businesses. I mean, I think the payroll tax being graduated by income, you know, that I think that's going to tend to affect businesses that hire professionals and technical folks. I think the existing employer contribution system is a little bit more flat, right? You know, premiums are premiums. But I'd be curious in seeing what's been produced to date.
Yeah, I think also from, if my memory serves, was discussion on co-pays and some of that as well, which would add another layer of, I don't know if winners and losers, that's a tough terminology, I know it sounds, but that would also change some of that distributional final impacts on how people are consuming healthcare today and how that would change going forward and what their cost sharing would be, I suppose. I think Samantha, you're next.
Yeah, I think just jumping off of that, I mean, the reality also is that we have tiers of coverage in this country and people can choose their deductibles, and participating in high deductible health plans, and the young and healthy want to choose the ones that are the cheapest out of pocket with premiums. It's under this plan, it's presumed that the benefit would be the same for everybody. And so you are going to see folks who traditionally have gone for lower cost plans because they don't utilize healthcare as much, suddenly kind of increasing the cost, and you're having more of a community risk approach. So I just want to point that out when we're thinking about what is the impact on individuals' pocketbooks and how does that vary?
Yeah, I think that's a great point, and it does bring up even some of the age considerations of the tax basis. And you know, Social Security being an example of something not taxed, but also just that retirement income maybe brings that back as well, and how to address that, because you could have a payroll tax, again, or there's going to be those in the labor force, which might be different than some of the consuming healthcare as well. And I think John.
Yeah, this conversation just reminds me, and I'm sure staff will chuckle a bit. The task force did have Optimus do an analysis of, gosh, what, 25, 50 different scenarios of people in different income levels and situations. You know, so that information is there. I can tell you that analysis was one of the reasons why the task force kind of said, I think we've gone far enough here, because it was very complex and difficult to predict. You know, for example, what I recall is that, you know, the payroll tax is imposed on lower income people. So that actually, from a relative income point of view, lower income people were significantly affected by a payroll tax. So I think to some degree, the analysis that you're talking about is there. It's very complex and interesting, and I don't know whether it's worthwhile going back and revisiting it. I'd turn to staff for their sense of that. But this is very, very tricky stuff.
Thanks, John. In the interest of keeping on schedule, Kyle, if you could go ahead and finish up your last couple of slides here. Please proceed.
That sounds good. So yeah, the last one I have for you, just moving forward, is it's a table taken from the final report. I think it was from the appendix, but it really is trying to tie a lot of this information together. So in terms of, Katie, if you want to advance just one more slide. This is that final table, and it's trying to show the revenue estimate in terms of the current baseline, the status quo, if you will, and then compare that to moving to the single payer. So that's the single payer column, and then you have that difference. And it's really trying to show where are we today, and then where are we going under a single payer. And so that the highlighting you have right now is really that new revenue, that 19.93 billion in terms of the difference, is that new revenue from the payroll and personal income tax. So that's the slides I just discussed. And then Katie, if you want to advance one more, you are having a change in revenue sources though. So here you see, before was new revenue coming in. This is revenue, I guess, not being raised, you would say, from the healthcare system. And that's the employer, the employee health insurance contributions, the individual healthcare costs. And that's where you see the negative. And in many cases, you're talking from a net perspective, a shifting of the dollars that almost come out to almost the same amount. There could be savings in the healthcare system. I know we're talking about what assumptions those would be used. But in many cases, you're talking about shifting it where the revenue is coming from. But where those chips fall on the individuals, the households, the employers, that's the big question for us. But that's what this final slide was, just to show that, because that was one of those things I think was important in the task force is, it sounds like this is 19 billion in new or 20 billion in new revenue, but it's not. It's also important to remember the costs that are going down on the other side. So it's like it is new revenue, but from an employer perspective, from an individual perspective, it's going to depend upon what their current costs are today on whether this new revenue is more, less, or the same as what they're doing today. But again, that was very condensed of the information the task force had. But this is a pretty good, or hopefully a high level overview of the discussion that occurred over many months, done in just a few minutes. So thanks for your time.
Richard, you have a question?
Yeah, let's go back to that previous slide. Kyle, I think this slide is useful, but I think an absolutely critical thing that we need to add to this slide is on the third line. You have to separate employee from individual. And then down at the bottom, you have to separate household contribution versus employer payroll tax, because they're huge amounts. But we got to know going into this, which is individual and which is by the employee or the employer. It has big ramifications. So I think we need to do another level of detail on those two lines. Over.
Yeah, thank you, Richard. And thank you, Kyle. That was very great. I've got more questions, but I'm sure we'll be able to talk to you again, and we'll keep track of more questions for you. So thank you, Kyle. Want to talk just a little bit about the principles for discussing and evaluating the revenue, what the task force used to decide what their important principles were. And if we could, next slide. So this is a list. We're not going to have a lot of time to dwell on these today, other than really want you to think about them. And I think we can reserve some time at next meeting just to go down through this list and to see if there are any that are different, since the task force did its work, or any that are additional. From having lived through the task force, I would just make a comment that there was a lot of misunderstanding about what the word progressive meant, and just whether it meant that every individual component of tax had to be progressive, or whether to look at the entire system. And the task force felt like looking at the entire system was the right answer. Charlie, I see you've got your hand up.
Yeah, so related to me, another piece that needs to be part of this is fair in the sense that all income is treated equally. And I think that what was proposed by the task force failed on that, because it taxed employment income a lot more than others, because it was taxed both by an employer, from the employer side, payroll tax, and also from the income tax. And to me, that's something we need to avoid. And to me, that's a principle.
Kyle, are you still here? Kyle is gone. I just wanted to get him to quickly talk about stability. Actually, in downturns, wages are one of the more stable sources of income. Business income tends to waver a little bit more, and capital gains can virtually disappear in downtimes, because no one is selling the depreciated assets, or if they do, there's no profit involved. And permanent, predictable, scalable. Of course, you don't want to get started on a tax that isn't big enough to handle future increases. ERISA is a big consideration, and we'll be covering that in a later meeting. And dedicated trust fund. And one of course, the goals of that is to stay away from some of the rules about our regular state income tax. We would prefer, for instance, not to have the kicker apply to our healthcare tax. But that is going to be a matter of future discussion. Then maximizing federal dollars was a goal of the task force. Next slide, please. So now we have can consider some additional principles. One of the things, is we're designing a tax. It's kind of meaningless unless, it's inconceivable to most of us that universal healthcare tax would be passed without a vote of the people. And so actually, I believe that some consideration should go into, and this can be done in conjunction with our community engagement committee, what kinds of taxes might be more tolerable. We're really trying to match people's frustration with the existing system compared with their interest in potentially changing the finance system. One of the goals that was from the task force that was not listed on the last slide was that we really don't want to create any situation where one group of people moves in or out of the state. And that's when we're doing a state-based single payer system, we really have to be concerned about, particularly neighboring states, and is there any incentive to move in or out? There's some discussion in the task force was on the idea of a broad base, what people call bubbler, a BBLR, a broad base low rate, is better than dependence on a high rate on a narrow group, which can then change their behavior or something and diminish the amount of revenue. Of course, one of the things that we need to be sensitive to is we can't just be looking at the cost of operation. We have to be looking at the costs of startup and the cost of reserves. We'll talk a little bit about that later. And that all of those costs must be included. Next slide. So, since we're running up close to break time, this is just a discussion question for you to think about. For next time, does the committee want to recommend any, what kind of principles do we want to adopt? Do we want to just kind of continue the ideas of the task force? Or do we want to adopt any specific language about avoiding big change or hardship to any group? So have time for just one or two questions on this if somebody has any comment at the moment. And if not, then we will go to break, and we will reconvene at 10:40. Thank you.
Lauren, it's 10:40. You can take it away when you're ready.
Okay, thank you. Do you need to resume recording? Or is it still on?
We are good to go.
Okay, thank you. Let's have the first slide up, please. For those of us who served on the task force or followed that, a lot of the work on actuarial analysis was done by CBIZ Optimus. So we'll now look at their work since that was a limited term contract. We can't have them. There's no way for them to come and report on it, but having been there as a task force member and having worked on the materials, I will go ahead. The materials in this presentation come from pages 39 through 45 of the main task force report, and also from Appendix B, which was written by CBIZ Optimus. Some of the tables are pretty information dense. I have added some graphics to make some of the concepts easier to understand. Next slide. Optimus's approach was to start with some basic data gathering on a base year. The year 2019 was chosen because it was one of the latest years for which significant data was available, and 2019 was not considered unusually high or low in its expenditures or revenues. Step 2 was to use the 2019 data and some trend computations to project what the base expenditures might look like in 2026. And step 3 was to estimate the effect of a universal health plan in 2026 compared to what that year might have looked like under the existing system. Next slide. Optimus identified its data sources as national health expenditure accounts, also data from Oregon Health Authority and Legislative Revenue Office, when such state data was available. The National Health Expenditure Account, one of the most commonly researched and referenced data sources for national data, also provides some state information. Optimus also relied on Kaiser Family Foundation and a number of papers by experts in the field of universal health care. Next slide. The task force gave Optimus some basic design assumptions. All permanent Oregon residents would be covered. Military, Department of Defense, Veterans Affairs, and some others were excluded from the study. Benefit plan would be the equivalent average PEB coverage levels, including dental. All cost sharing was to be eliminated for covered service. That means no co-pays, co-insurance, or deductibles for covered services. Provider reimbursement, which is vastly different now for Medicaid, Medicare, commercial insurance, was to be normalized to one common rate. Private insurers would not be allowed to sell insurance covering the same services as the universal plan. Next slide. Here is a list of persons and services excluded from the study. Care otherwise budgeted for a specific purpose or specific population not open to the general public was excluded, including, as mentioned, DOD, VA, Indian Health Services, institutional care, employer-provided worksite care, all of which total to about 4.5% of total care in the United States. Research and investment, which is also tracked by the national expenditure accounts, was excluded because we only wanted to study funds spent on direct personal care. Population health, such as CDC, restaurant inspections, other services, also was excluded from the study because it didn't, to the extent that it does not include direct personal care. The cost of services and facilities funded through private donations was excluded, and this can be actually fairly significant, in the order of 5%, according to the National Health Expenditure Accounts. Out-of-pocket expenses for services not covered by the plan were also outside the scope of study. And this was a hard one for the task force, but long-term supports and services, often called long-term care, were excluded except as already provided through, specifically through Medicaid. The task force itself excluded the long-term care because it was concerned that including it would make taxes unfeasibly high for the public. Next slide. Although Oregon's percentage of uninsured has been decreasing, helped in part by Oregon's Bridge Plan, which started in July, and other programs, the remaining uninsured population is not a homogeneous group, and the effect of including them is actually kind of complicated to estimate. Large portion of the uninsured population would qualify for Medicare or marketplace subsidies if they would just sign up. So in some degrees, you could say that Oregon is missing out on federal Medicaid dollars by having them uninsured, and would benefit by having a program in which everyone is covered, and these people would actually then be, as long as the waivers are available, would actually be generating federal money. Another portion of uninsured is younger people who could afford insurance but choose not to buy it because the cost is very high and their need is low. Yet another portion of the uninsured is people who have unmet needs because they can't afford care, do not qualify for existing programs. Next slide. As mentioned, one of the problems which the task force wanted specifically to address was the disparity of provider reimbursement depending on who the patient is. According to actuarial data from Optimus, help from Oregon Health Authority and others, Medicaid in Oregon now pays just 69 cents on the average cost of providing $1 of care. Medicare pays 81 cents. Private insurance has gradually risen to $1.37 to make up the difference from declining Medicare and Medicaid reimbursements. The problem is fewer and fewer providers are willing to accept Medicaid, Medicare patients, or they put limits on the number of those patients that they will see. Next slide. Here is the first table from Optimus giving their calculations and estimates for Oregon's base year, 2019. Next slide. Looking first at the enrollment figures. Next slide. This chart shows the breakdown of how people are covered covered for Medicare. According to the Optimus study. About 3% get their care on the marketplace exchange, 47% are covered by other private insurance purchased individually or through an employer, 19% are covered by Medicare, 24% are covered by Medicaid and CHIP, and according to Optimus, about 7% of Oregons are uninsured or were uninsured in 2019, according to Optimus. Optimus acknowledged that this 7% number is several percent higher than estimated by the Oregon Health Authority. Next slide. Now, moving on to the baseline expenditures. Next slide. Insurance paid for insurance paid for individuals and employers, paid for by individuals and employers, covers about 35% of all costs. Medicare and CHIP count for about 28%. Medicare covers about 25%, and out-of-pocket and payments by uninsured other sources account for smaller share of the total expenditures. Next slide, please. Optimus's next step was to extrapolate the 2019 baseline information to 2026. The projected total population, this of 4,432,700, was obtained directly from projections made by, next slide, by Department of Oregon Department of Administrative Services. Next slide, please. Yes, there's the number right there from the from that graph. Now moving on to the next slide. For estimating how much expenditures would rise on a per capita basis, Optimus used trend information from the National Health Expenditure Accounts. And by the way, I missed saying something important. When Optimus estimated the increase in population in the state, they assumed no difference between the percentage of people on Medicare, Medicaid, private insurance. They assumed that there would be no trends between those and that they would all stay the same. Now, continuing back onto expenditures, Optimus used trend information from the National Health Expenditure Accounts. Next slide. Here is a graphic depiction of the Optimus's estimates based on the National Health Expenditure. The top of the blue is the low estimate. The top of the orange is the average which Optimus actually used. Top of the gray is a high estimate. According to these estimates, Medicare costs per person are increasing far more rapidly than other programs. Medicare and CHIP show as showing the most uncertainty between low and high estimates. One of the criticisms that some of us had of Optimus was that we would just get one estimate without a range of error. And this, with the help of the National Expenditure Accounts, kind of shows that we're taking some guesses within a range for each of the components of health funding. Next slide, please. So now we get into making the changes for what happens when we switch from the 2026 status quo expenditures and compared with under the assumptions under a single payer system. The figures in that column contain a number of effects, and some of them are opposing. It helps to consider the effects individually. Note in the lower right-hand corner that Optimus' estimate of total effect is a savings of here. They've other places it's rounded to 980 million. Shown here is 977 million, just due to the rounding differences. Next slide, please. Much of the effect shown on the previous table 8 is from raising the amount paid for Medicare and Medicaid patients while lowering the reimbursements for private insurance patients by paying the average cost of $1, regardless of who the patient is. Next slide. Other impacts of a universal health care system include increased medical system utilization due to removing financial obstacles, upgrading all insured people to the PEB benefit level, covering the uninsured, and counteracting those increased costs are savings from improved purchasing power, administrative savings, the potential for decreased fraud, waste, and abuse, and removal of insurance profits. Next slide. Optimus's specific estimates for each impact are shown on this table 6, but are more easily understood in the following graphics constructed from this table. William Shaw, regarded as the leading authority on universal care savings, estimated that the universal care system could reduce provider billing costs by 8 to 12%, meaning that provider reimbursement costs could be reduced by 8 to 12%, eliminating billing staff, but without lowering the income to providers. The task force voted to reduce payments to providers by only 4%, leaving an extra 4 to 8% to be targeted toward behavioral, regional, and primary care. Next slide. Besides the potential savings in provider administrative costs, lesser savings were estimated by Optimus to come from removal of insurance commissions and marketing, economies of scale, insurance company margins, increased purchasing power for drugs and other supplies, and savings from making it easier to detect fraud, waste, and abuse. It is important to point out that the task force intentionally planned for no savings from reducing the aggregate net income of providers themselves for delivering direct patient care. Next slide. Optimus also estimated the increased demand for care, which would result when there are fewer financial obstacles for patients seeking care. Reading from bottom up, estimates are shown for the increase in utilization from an elimination of cost sharing, such as copays and deductibles, increased access to Medicare and Medicaid, improving benefits for everyone.
Could you go to the next slide? Because I think you were on the wrong slide.
Oh, thank you. Thank you. Reading from the bottom up, estimates are shown for Optimus for the increase in utilization from elimination of cost sharing, such as copays and deductibles, increased access to Medicare and Medicaid, improving benefits for everybody to be at the PEB level of coverage, the addition of an inclusive dental plan, and covering those who are currently uninsured. As mentioned earlier, the task force voted to go beyond these increased services by setting aside 4 to 8% of the total cost in order to improve services specifically for behavioral, regional, and primary care. Altogether, then about 8 to 10% more services are provided while still reducing the cost by almost 2%. The task force and now the governance board can choose between increased services or lowering the cost of healthcare closer to what it is in other countries. Next slide, please. So there again is kind of a summary. We'll go right past that. Next slide. Optimus estimated out for into 2030 from 2026, estimating that the savings would gradually begin increasing particularly with years 4 and 5. And part of that consideration was that there would be a bubble of pent-up services. And once that bubble was worked through and people got the care they need, we would approach a more stable situation of need. So you can see that the savings is increasing as time goes on. Next slide, please. Legislative Revenue Office, Kyle covered some of these graphs earlier in our meeting today. So I will skip to a graphic showing where the revenues would come from. So if we could just skip a couple of slides here, Katie. And yes. According to and all of these informations are on different slides. So I believe I have this right, but we can look at it further. Households would pay less under the new plan. For a variety of reasons, employers were computed to be paying at about the same. Federal Medicare, assuming that waivers would be in place, we figured exactly the same, that money would just be handed over to the state single payer system. But if you look at the Medicaid bar, there was discussion within the task force that since Medicaid actually doesn't have a fixed schedule, but they will match up to a certain point, will match what the state pays for Medicare patients. So the fact that Oregon would be creating or paying more for Medicaid patients, an estimate was made that we would qualify for $2 billion more in federal funding for Medicaid patients. And the bar for the state of Oregon, you should be just a little bit cautious about that because there was some consideration by the task force that part of the funding would come from money that currently pays the healthcare benefits of state employees. And there was an argument on the task force, and presumably will continue on the governance board, who owns that money. Some argued that's taxpayers' money, and we should be able to divert it directly into the single payer fund. Others would argue, no, that's worker money that's been fairly negotiated for, and if there's any change in that, or any reduction in that, for instance, in private employers, that the same treatment should be given to public employees. Next slide. So here in summary, we have Optimus's estimate. When you pour all of those things in the box and shake it, out comes $980 million of savings in spite of increased services. Next slide. If you read the final kind of disclaimers and concerns that Optimus wrote into their report in Appendix B, that they made no estimates for the costs of startup, which could be significant, as a new system must begin ramping up well ahead of the actual implementation date. And the old system will presumably continue to generate some costs due to gradual run out of claims, potential of employment, unemployment benefit claims, or retraining dollars for displaced workers. Information technology is its own consideration because the software require significant advance investment well ahead of the changeover date. Optimus refuses to offer any opinion on the amount of operating reserves, but other medical entities typically operate with a minimum of 6 months worth of expenditure cost. Because of the large patient pool, year-to-year fluctuation in expenditures might suggest that a full state system could get away with a lower reserve. But we also, on the other side of the coin, taxpayer revenue really can go up and down by quite a lot. And so the rainy day fund needed to ride out temporary downturns in tax revenues could mean that it would actually need a larger reserve. And those arguments will need to be conducted by the governance board. So next slide, please. One of the really interesting things is to me, is the task force began by contemplating that, and in fact, it was written right into Senate Bill 770, that the single payer system would cover people who live outside of Oregon but work inside of Oregon. And that number, including their dependents, that's about 287,000 people, which would generate about 255 billion in revenues. The task force actually said, "Hey, wait a minute! One of our goals was to uncouple employment from healthcare. So if we're basing this decision to include these people clearly and purely based on their status as being employed, then that's not right. And so this remains a decision to be made by the governance board of how to treat these people. Next slide. One of the last things that Optimus mentions in their report is they had this disclaimer: the Optimus model is a budgetary projection, not actuarially sound rates for the population with quantifiable confidence intervals. And that was just something to consider on that. Next slide. So we'll stop here just momentarily. Does anybody have any questions on that presentation? Richard?
Yes, would you please go back about 15 slides to the one on administrative savings? So the thing I'm trying to get to is that we see estimates of how much it costs providers to do billing. And I mean, I've seen some for health systems as high as 25 or 30% of their total revenue is spent on billing. Here we go. So how does that gel with this slide here? Because the margins are higher than just 12%, not the margin, I'm using the wrong word, that the cost of billing insurance for providers is higher than 12% of the revenue that they take in from insurance companies. Is that a fair statement?
Yes, and I think it's important to mention that these are aggregate, so they contain hospitals that may have a higher percentage of billing cost. It includes dentists who may have a lower percentage cost, and so that is one answer. And I might mention that when you look through the Optimus study, they depended pretty much entirely on the paper written by William Shaw, calling out the 8 to 12%. And that was not the total cost. That was the cost that they believed that could be saved by switching to a universal care system.
Even that seems under. I mean, who am I to challenge William Shaw? But still, it just seems like that's an undercount. The other thing on this slide is, where is the provider? Where is the payer administrative cost? I see the insurance margin and I see the marketing, but where is just the administration of health insurance companies? Why doesn't that show up here as the savings? Because we don't want to double count between the cost of providers, their administrative savings versus the payers. But still, where is the payer administrative savings here?
And this was partly by task force decision, the total administrative on the payer side from national health expenditure accounts and other estimates was like 9%.
Right.
And so if you deduct insurance margin, marketing, and some other things, you get down close to 6%. And Optimus recommended that the cost of operating the state system would be about 6%. So that's, I mean, it's not clearly visible, as some of Optimus's work is not clearly visible. But that's where that is there's, there's about 3% savings here. And the assumption that the state system would run an administrative cost of 6%. The task force members of themselves, many thought we should be able to beat that, and suggested 4%. But we ended up at 6% based on Optimus's recommendation. That's, as Cheryl mentioned earlier, a lot of the assumptions in here are conservative, and the task force intended them to be that way. So that was, we were moving on the payer side from 9% to 6% average cost of billing. So, John.
Yep. First of all, Warren, boy, I congratulate you on a very good performance on a complicated topic. Every time I read the Optimus report, I learn more. I, realize what I had forgotten. And but one aspect you mentioned, but Optimus did not do a more detailed analysis of. But you can see in the numbers the huge shift in dollars because of what we termed normalization of payment. That the payment for a Medicaid patient would be the same as a commercial patient. Think about it. And Chris, I go back to your original comment about rural issues. Every rural market I've been in has a predominant Medicaid and Medicare population, overwhelming. They're in the 20, 30, maybe the more affluent rural places get up to 40% employer. There would be a huge shift because of this normalization process. And I think that's an aspect that the task force was very strong in supporting, but wanted to make sure that was mentioned, because while Optimus focused on the magnitude of the shift, they didn't talk about, well, who would benefit and who wouldn't.
Thank you, John. Charlie.
So another thing that we need to keep in mind when we're looking carefully at these things is calendar year and fiscal year, because the National Health Expenditure accounts are calendar year numbers. The MBES reports that the state puts forward are federal fiscal years, and I'm not quite sure about some of the stuff that comes from like the CCOs. I think they may even be Oregon fiscal years, which is 3 months earlier than the federal fiscal year. So if we're going to be good to within a few percent, we need to worry about whether which year is this, which fiscal year, or is it calendar year, whatever it is. So just we need to be cautious about that.
And optimists seem to include some of that. As I was tracing some of these through, I seemed to, in their growth rates, it seemed to be kind of based like a half year, whole years plus a half year. And I wondered if that was a stutter step to get in sync. Those are things that we need to stay aware of. So thanks, Charlie. Chris.
Yeah, a couple things, just thinking about John's thoughts, and how the service area of my CCO would be affected by that renormalization of rates. Advanced Health is a pretty cool organization. I think it's a CCO that's owned locally by the various health entities, and one flexibility that's given us is to find unique solutions to the problem that John describes, the high penetration of Medicaid and Medicare, relatively low rates of commercial coverage, and we do that by saving money and paying providers fairly for Medicaid. So Medicaid reimbursement in Coos and Curry counties is actually quite good. So I wonder what would happen if commercial rates were decreased and Medicaid and Medicare rates were increased. If they're made equal, I think it may be a net negative for certain rural regions in Oregon. And the other thing that was on my mind was that overlap. So suppose we have a system that's perfectly balanced, and we're offsetting those increased future costs by future savings. How long is that overlap period, and has there been discussion of how that period would be financed? So my understanding is these new taxes would kick in at the same time individuals and businesses would be continuing to pay the premiums of the status quo. Is that right?
There was no decision made by that on the task force. Again, was kicked down the road to the governance board. There is, when I think of that, I think about potential, instead of starting double paying for a period of time, also considering the idea of bonds that are amortized over a period of time. And that's all some of the exciting work that you get to work on, Chris.
Right.
Samantha.
Somewhat similar comment. I mean, I think that the thing that is really on my mind is, how will that payment rate impact provider participation? Especially in the behavioral health space, you have folks who are opting out of insurance altogether and can sustain themselves on a private pay situation. So if we're suddenly bringing down commercial for those providers who are still taking any insurance and it is commercial, what does that do? And in tandem, thinking about how we have a telehealth industry that is increasingly supporting a private pay market. So that's something to think about. And speaking of private pay, I mean, I was curious in the overall healthcare expenditure data if they tried to account for that, and if so, where that shows up in the data.
I don't think that was really considered, and also something Chris pointed out, a weakness or a optimist did not attempt to address that there really are kind of two situations, urban and rural, who are facing different kinds of things. So they're treating the state in aggregate, when those of us who live here understand that it's not quite that clean. So yeah, well, your comments, Samantha, are appreciated, and those are things that we need to include. Richard.
Yeah, the other comment I had was about the categorization of employer. If you're a standard employer for of 500 or more employees, I think that's fairly straightforward. But the two kinds of employer that I think we need to get more detailed data on is those that are self-employed, and are they categorized in the employer group or in the household group? And there's a big difference there. And the second thing is that what about employers that don't currently offer any health coverage at all? So they get taxed, but they presumably with employer payroll tax, but they don't currently pay employers. So I think we need a separate category for that to start to understand the cost shifts, not to focus on winners and losers, but that is an important sub detail I think we need. Thank you.
And Richard, that was one of the things that helped kill the proposal, that we were kind of trying to raise the same amount of money from employers generally, but taking less from the from higher margin people, and taking more from low margin. So an example of someone who testified before the task force was a cherry grower in Hood River who said, okay, so you're going to charge me a 7% payroll tax. My margin is 3%. So if you don't want any agricultural products raised in the state, you know, because we can buy cherries from Washington. So, you know, these are things that we really have to wrestle with, but that was one of the things we didn't have an answer for. So we'll wrap up that and move on to the next topic. I think many of us who were on the task force kind of kept a mental note of kind of lessons learned. What would we do different in hiring a new contractor? What would we do different in the work that we do? And so I sent out to you a 2 or 3 page document for you to read and consider on the proposed attributes of a sound universal health plan. Got feedback from Charlie, at least, on that. But what I would like to do is, since we have the Optimus presentation fresh in our mind, is just to review a couple of items from that, and maybe some things that we might want to change this time around. And I might mention that these few slides were not in the board packet. They're included just to help clarify the discussion, and they are available on the website. Next slide, please. So, you know, let's talk about the Optimus model not being actuarially sound. And, you know, for me, okay, so we're going to get ready with our implementation plan, and we're going to invite some bankers in to talk about loaning us some money or something. And they read this statement. I don't think that that's, you know, I think we need to consider, you know, the standards which we set for the actuarial work that we have done. Next slide. So I'm just proposing a short recommendation that that our work, and including contracted work, be based on fiduciary accounting standards with confidence intervals, the things that Optimus said their study was not. Of course, this raises the cost, so we have some trade-offs here, but you know, we really need to consider, are we going to do something identical that was done before, or we really need to raise this to the next level so we can implement it. Next slide, please. Something that I noticed in Optimus's work, and you note down there, there's a baseline column. It comes up with 37 billion $570 million. And now it's transferred to the next slide. Next slide, please. And you see suddenly the same set of numbers adds up to 39 billion. Well, makes some of us say, well, okay, some kind of an adjustment was made there, but they didn't identify in the report what it was. So next slide, please. So certainly something that I've learned and would recommend in our work. You know, we show our work. There's no hidden adjustments. Next slide, please. And kind of a similar thing here. And if you look down at the bottom, it just barely shows, here's Medicare money, but we can't tell how much of that is coming from Medicare because Medicare out-of-pocket cost is included in the Medicare total. And Optimus did not break it out. And this was a particular aggravation. You know, I remember spending hours with Charlie saying, you know, why don't their out-of-pocket costs add up? So next slide, please. When you see that those bigger numbers, suddenly the numbers get smaller when we're collecting money from the federal government. So is that the out-of-pocket costs that's missing that explains the differences? I mean, this is an example of, so next slide, please. So something that I really like is the idea that in this work, everything must add up to known data based on a stable methodology, such as the National Health Expenditures, MBES, or some other things. And it would be so helpful if in their work they would just spell out to say, in order to get to the total, you have to add these things and subtract this. But they didn't do enough of that to make the work easy to follow. Next slide. And in tracking that data, something that I've really come to believe, when you start making all the adjustments to 2026 data, there's no way actually to track that because there aren't any, you know, the National Health Expenditure accounts for 2026 surprisingly haven't been published yet based on actual data. So it would be really helpful if we actually made adjustments to a known year where tons of data is available and we can cross-check some of these things. So my own recommendation would be to actually switch the order. And looking at the National Health Expenditure accounts, if you look at those, and next slide, please. So here I just threw up a quick slide of National Expenditure accounts has certain categories: hospitals, physicians and clinics, dental, other professional, etc. Well, in a lot of our work, we think about, you know, the explosion in behavioral health needs. When we're going strictly by national health expenditures, it's not granular enough for us to do our work. So we really need to figure out additional categories that we need to track, including things like primary care. Would be nice to have those costs separated out, and maybe some other categories. Next slide, please. So that's just adding to my list of recommended attributes, and in conjunction with talking to others, that we must break out behavioral primary care and possibly other categories that are not tracked separately in the National Health Expenditure accounts. Next slide. So here is another thing. The Optimus study was not a closed study. It was only looking at part of the system. So it treated money coming from Medicare and Medicaid as if those were payers. But in actuality, they take in money. I mean, they're middlemen. They take in money and they spend money. So in this case, we tracked carefully any change in state taxes in order to track the cost, but we were spending $2 billion more in federal money on Medicaid without stopping to ask ourselves, should we be considering the effect of that? Is it likely to raise federal taxes? So that is just something that I've earmarked as an example of needing to look at total systems rather than partial systems. Next slide. So that included here must include all revenue spent on healthcare, including the taxes which support federal programs. And next slide. The assumptions that the task force made, or that Optimus made, to disregard services and facilities that are currently paid for by private donations, I don't think is a good one. I think it needs to be looked at a little bit more. If you have 5% of the total healthcare costs that's funded by private donations, and then you switch basically to a government system, I think you have to assume that private donations may well go down. And what do you do about that? Do you have to raise more taxes? Similarly, we really do need accounting for 4 to 7% of the costs, out-of-pocket costs, which were not fully identified by Optimus. What are those? And I know many of you are concerned about long-term supports and services, also known as long-term care, and might wish to pick up the ball on what the task force just decided to push off to the side. Next slide, please.
Warren, could I interject a question? Go back to the previous slide if you could. The research and investment in national health expenditure accounts also includes the capital costs, so major improvements. And it's likely that for all sorts of reasons that the system that we want to propose is going to have that as part of its costs. And so it seems to me that the investment part of that, the capital investment part of that, should also be included. And I might even argue a little bit about the population health, since I think from COVID we learned that it's sometimes very difficult to break apart personal health and public health. And so it seems like we might at least want to have that in our consideration for a while, and to see how we need to deal with that. So to me, those are two other things that we need to think about, including in the scope of our study.
Yes, that's actually very important. And when you think about global budgets, for instance, how much of the global budget, I mean, if a hospital, for instance, has bonds that they're paying off from some sort of a building, or how do you treat them fairly with another hospital that doesn't have that debt that needs to be paid off? Those are issues that are kind of down in the weeds for most people, but the details of that really have to be worked out before you can implement the plan. So thanks for all of that, Charlie. And next slide. And going back to William Chow's statement, which is just kind of general, his assumption was that if you switched everything to a single payer, that you could gain the 8 to 12%. There's not enough work done on if you leave some things still, if you leave some things out, say that we don't include Medicare. Are those savings still valid? Study done by Colorado School of Public Health said that if you didn't include everything, the cost would actually go up instead of down, because you've not reduced the number of different payers that you're having to deal with. So we didn't get firm answers from Optimus on this, but I think it's going to be a fundamental part of our consideration. So I'd like you, if anybody has any comments on the 3-page document that was sent out or on these recommended attributes. Chris.
I don't know if there's appetite for more actuarial analysis, but if there is, I think another possible weakness of what's been done so far is the reliance on 2019 data. Granted, trying to forecast out 6 or 7 years is never going to be perfect, but in the intervening years, we've had a pandemic, kind of a restructuring of our economy, telehealth. These are all huge factors, and I think many of them may be persistent.
Chris, that's perfectly said. And, for myself, trying to think about what would be good study years. And I don't believe in studying a single year, because you're not getting the year-to-year variation that you need to keep track of. But using the COVID years in some kind of trend analysis, it's just not stable enough. So you have to make some assumptions, as you said, what effects are persistent and what are transient. So again, you're the right guy to help us figure that out, and by knowing that the question needs to be asked. Richard.
I have a bigger process question. Today's discussion across the whole last 2.5 hours, there have been a number of suggestions about how to get more detailed data and break it apart category, and I've offered a few of those myself. So what is the expectation that if I could wave a magic wand, what I'd say is between this meeting and the November meeting, that we get consultants or analysts to go through and add that level of detail, so we don't get back here next month and say, we still don't know any more than we knew in October. I mean, that may not be realistic, but I think we need to set the expectation of all these suggestions that are being made to help us understand healthcare costs and where it would go. What can we use consultants promptly to turn this around before our next meeting? Over.
Some of that I might turn over to Morgan. We've got different levels of consultants, some that can do a small, easy task for us, and some that will take many months to set up a contract. So I think for me, the focus initially is to be sure that we have the right questions, and then we figure out how to get them answered, which ones we can answer quickly and which ones will take more complicated contracting. I hope that addresses your comment, Richard. John Santa.
Yeah, Warren, I think that document is a terrific document, and it's the way things should be done. The question is it the way things can be done? Does the Universal Health Governance Board have the budget to afford doing things the way that document outlines? Because I think in some cases, as you just said, some of the issues will be very complex to figure out. A consultant isn't going to be able to make much progress in a month on some of these issues. And some of them raise very serious questions. your comments about donations, I think, are interesting. For those of us who have followed the healthcare market oversight process, every hospital has a foundation. I was reading through the OHSU legacy documents. You know, there's a Good Samaritan Foundation. There's an Emmanuel Foundation. There, as you know, in Corvallis, we learned there was a Corvallis Clinic Foundation. You know, in the Care Oregon transaction, we learned there was a Care Oregon Foundation, or one that was proposed, and I think there is one. And the Care Oregon had a $1.3 billion reserve account. So you know, those monies are there. Those reserve funds are there. They should be helpful in any transition, and those donation funds should continue to be there, and I think should be a resource we should look at. But that's a very tricky, complicated, you know, try and figure out what's going on at the Good Samaritan Foundation. I spent the day trying to figure that out, and it's not easy. And I was, you know, trained and worked there and donated at various times there. But it's a complex set of recommendations that I'm personally comfortable with. The current system certainly doesn't adhere to that kind of approach. You know, the legacy OHSU deal, I'm not sure would adhere to many of the principles you've declared. So there's a lot in this.
Thank you, John. Samantha.
I just want to plus one the need for more analysis. I'm already creating my wish list, and I will propose that perhaps members of this committee can send initial thoughts perhaps in the next week to get that going on what the priorities are. I also agree that the 2019 data is very dated, and I don't know really how useful it is as a baseline to look at. I will say for this document, for the principles document, equity should be number one. I'm presuming that the principles list would apply to the recommended attributes as well.
That sounds good. Before we move on to the next topic, and because of the timing of the board meeting, we actually can't make a recommendation to the board. Board meets in 2 days. So actually voting on a recommendation might be a little bit premature given the range of discussion. But I'd just like to ask if anyone kind of objects to the kinds of attributes which are presented in the 3-page document, or these list of 7 recommended attributes. I mean, do we have general support on this? Okay, I can't see everybody, but I see 5 fingers sprouting up. So I can't see everyone, but and hearing no objection, we'll kind of assume that some of these things are important to us. So now, Katie, if we could move on to here, and actually, if we could stop the share screen so that we can see each other better. So this is a part of the meeting. And by the way, let me double check with Katie. We still have no one who is providing public comment. Is that correct?
That is correct.
Thank you. So this has been, you know, a pretty, I hope, a good start of our discussion. We've heard from LRO. We've talked about our own how we conduct business, and I encourage you to read the policies and procedures. Does anybody else have any thoughts that they want to share about about this meeting and the reflections of the what we're learning, and I think people have already offered a lot of suggestions about next steps. Charlie.
So to me, it seems like we have a lot of work that needs to be done by at least some members of this committee before our next meeting. And I was wondering how we go about getting some of that done and what should happen in the meantime. It seems like it's pretty daunting to when I looked at the timeline of what we're supposed to accomplish here by the next meeting or after the next meeting. And I don't think we're going to get there with what we've got going so far.
I think that's a great suggestion, and I might leave that up to Morgan and Cheryl for their ideas on how we might coordinate that.
Well, can I jump in there? I think Samantha had a great idea. If all of the members of this committee take a couple days to write down some reflections and thoughts of next step. I mentioned this when we were going through the work plan and introducing the other staff and consultants that we have helping us. Health Management Associates is already spending time updating the information that was provided to the Joint Task Force around the healthcare spending or expenditures. They're here listening to the conversation. I think, we'll be pulling that information together, and I think we'll learn a lot about what additional information is available since the Joint Task Force did their information. There may be some limitations beyond what's the desired level of detail and what is actually available, but we have partnerships with OHA to draw on, and we'll be pulling that information together. So we'd love your thoughts and sending us what you have in the next several days and getting everything to us by next Tuesday would be really helpful. One thing that we didn't spend very much time talking about at the beginning of the meeting was just the cadence of information for you all. It is absolutely our plan to get agendas out a week in advance so you can see the agenda. Our desire is to get materials to you at least 72 hours prior to the meeting so that you have enough time to review, to process, to develop questions. And I think we will try to avoid the kind of like last minute documents being sent out so that the meetings that we have, the 3 hours that are scheduled, can be as productive as possible. I do think we set the meetings so that there's a meeting each month and we can have that cadence, but we also would have the ability to schedule additional meetings if they were needed. If the committee just didn't have enough time to have the discussion or really dive in as they desired, we can schedule additional meetings. We just wanted to make sure that we had a predictable meeting schedule for you all to be able to hold some monthly meeting times.
And I would be one who would recommend more often meetings, particularly in this kind of setting, where we're trying to do a little bit of innovation, but we don't want to violate public meeting laws. Previously, the board has had some work groups which met, to talk about specific purpose, and you can. It's more of a chance to have an open communication, a little less structured, where we just bounce ideas off of each other. And, a few members of the public show up and it's fine. It works out good. So I would certainly advocate for having more frequent meetings with the idea of saying, hey, I got this idea. What do you think about this? Or we need that. Or and I really would hope that this group could really help drive the conversation. We've got great people. Richard.
I think the single biggest challenge for this group is ultimately getting the citizens of Oregon to understand and approve the plan we're coming up with. And I would like to propose for the group just to think about that ultimately, maybe in 12, 16, 18 months, that we have a calculator for the people of Oregon. And the inputs would be, obviously, are you employed? Are you self-employed? Are you an employer that doesn't offer insurance? How many people in your family? That sort of thing. And then also a big one is having a switch in there for if you don't get sick and if you get sick, because a lot of people think their insurance with high deductible plans is great. Hey, why? It's a great insurance. And then they get sick and they say, I don't really have any insurance. And we can predict all that. So ultimately, I'd like to have a calculator that's finely enough tuned that all the people, nearly all the groups in Oregon can put in there and see, here I am now, and here's where I wouldn't be under the new plan. That's a hope. Over.
Thank you, Richard. Cheryl.
I like the idea of a calculator. You know, it's really easy for someone to tell, you know, what it means for them, whether it's an employer or an individual. So I don't know what it would take to do that, but I like the idea. I just wanted to reiterate what Morgan said, and also Sam suggested, and that is to send your questions, as you said, your wish list on the data that you feel that we need, or we need more details on. And then I would say we can ask HMA and some of our other consultants whether it's doable by November 19th, our next meeting, and we'll just let you know what we can provide and what we can't, and we'll just do our best is how I see that. And then I also wanted to agree with Sam that I agree that the attributes intersect with the principles, and I think there may be a way to morph those two things together so they're really clear and understandable, and we all know what we're talking about here. I know I need a little time to mull over, so if you all have suggestions, that's another thing you could email to Morgan and me before the next meeting. That's what I've got. Thank you.
Excellent. Samantha.
I wasn't going to raise my hand, but Richard and I are like telepathically communicating on that calculator idea because that's what I've been thinking about this entire meeting. And I actually think having some fine-tuned controls for actual health utilization, expected health utilization is really important. And would maybe even challenge us to do a similar calculator for providers, you know, under this new rate structure. Here's what this does to your bottom line. Here's what we think you'll save on administrative costs, etc. And I'll just put a plug in for maybe an in-person meeting at some point. I'm always a fan of that. So I know we're coming from all different parts of the state, but I would certainly appreciate meeting folks in person.
Totally agree.
Thank you. John.
Yeah, I just want to clarify. So when do we send some things just to Morgan and maybe the chairs of the committee versus the whole committee? I mean, I get the sense that we should be very careful about hitting the reply all button or sending an email out in which somebody could hit the reply all button. And so if you could clarify that. The second thing I just say is I couldn't agree more with the calculator idea. But again, the task force did try to kind of do that with Optimus and look at several different, you know, scenarios. And so maybe the staff and consultants could summarize, you know, what the outcome of that adventure was. It was quite an adventure. I think I learned a lot, but it's very tricky to do that.
Thanks for the question, John. I will clarify. I think many of you, I hope all of you attended one of the orientation sessions where I touched a little bit on adhering to public meetings law. John, you are absolutely right. Please do not email the entire committee. Our council has advised against it because back and forth communication between committee members over time on issues that will come up in a committee meeting can inadvertently become an unnoticed public meeting. So to make sure that we are adhering to the state law and doing everything as transparent as possible, please send me questions, and you can absolutely include the board members that have the DCBS email. So right now, Warren and Cheryl, soon Cheryl, as she takes over chair. That is also a way to capture that communication into our state system and make sure we're catching those for public records. And so it's got a double asset. It's a doubly good thing. We and staff are capturing all of the suggestions. And at the next meeting, one of the things that the chair of the governance board, Helen Belanca, has asked all of the committees to do is have some conversation about additional resources or projects that might be resources that are needed for the work. And so I think conversation around a calculator, we will absolutely look back and gather what Optimus put together, but that calculator or kind of specific deep dive in that area is not something that's currently on the tasks or the deliverables for this committee, and would need additional resources dedicated to it. So that next meeting is the perfect time to have that conversation.
Yeah, Morgan, could you also clarify? Charlie mentioned an individual who's expert at global budgets. I personally would love to hear more about that, though it sounds like it's not our purview. But it brings up the issue of what are the boundaries around members of the committee talking one-on-one with folks in the community that they believe have expertise that could be of help. If they do, suggesting that, like Charlie did, that it might be of interest to have somebody on a governance board hear about that. So could you comment on that?
Yes, we are always open to suggestions and expertise to bring into this body of work, kind of. One of my thoughts is that at the next meeting, we can also talk a little bit about what the other committees are working on and look at their purview, so you can see where some of this work that might not be happening at this committee may be happening. And I think that suggestion for provider reimbursement global budgets is a great one for plan design and expenditures. And I think one of the things that we can do is make sure that members of this committee are aware of when those conversations in other committees are happening. So you could listen in if you were interested, and make sure that we want to make sure that all of the participants in these committees are getting the information that they need to contribute. So we are very open to recommendations and suggestions. Thanks, John.
Chris, do you have a comment?
Yeah, I'd like to join in expressing my interest on the topic of global budgets. I think it intersects with the question of sufficient reserves. So if we're transferring risk to providers or organizations like CCOs, for example, that changes the picture from the state funds perspective. Lower reserves and lower costs.
And Charlie, short comment. Unmute.
One of the important things regarding the calculator is going to be the estimate of what somebody is paying now. And among the important things that's often forgotten is what their employer is paying now. And I'm wondering, we need to work hard probably to include that. And I'm wondering how many employers provide that information of what they're paying for employees' healthcare on the tax statement to that employee. Is that done by most employers or just a few, or how does that go? And how can we make sure that people have that information, or to the extent possible, how can we help it make that information there? So.
Excellent. And as we come up on the hour, I just want to say that T.R. Reid is most famous for his bestseller, Healing of America. Wrote another book called Fine Mess, which is about taxation. I love the book. And in fact, in other groups I've worked with, I bought a dozen copies and passed them out, and people found them interesting. I had breakfast with T.R. Reid and told him that I'd bought a dozen copies, and he said, wondered why his royalty check doubled. People don't buy books about taxation. But anyway, I've bought a copy for everyone on the committee, and we'll be figuring out how to get that to you. So thank you for, I think, a very excellent meeting. Thanks for everybody's participation. If you feel lost, we need people who are know some kinds of numbers and some people who know other kinds of numbers or just know a little bit about wisdom. So hang in there. Thanks for being a good group, and we'll keep you posted. So meeting is adjourned. Thank you.
Thank you. Bye-bye.
Thanks, everybody.